Good evening, everyone. I'll start with the case. It is a 41-year-old male, security guard by occupation, never smoker, chronic tobacco and alcohol consumption. Patient complains of shortness of breath for 3 months, cough for 2 months, and right-sided chest pain for last 2 months. Patient was apparently asymptomatic before 3 months. When he started to have shortness of breath, which was insidious in onset, gradually progressed from dyspnea while climbing 2 flights of stairs to the state where patient is breathless while carrying out his routine activities like walking till bathroom or changing clothes. Patient also complains of insidious onset cough for past 2 months, gradually progressing, dry in nature without any diurnal variation, partially relieved by the over-the-counter cough syrups. Cough is associated with dull aching, non-radiating right-sided chest pain, which is exacerbated by cough. It disturbs sleep of the patient such that patient is more comfortable while lying on his right side. There is no history of pedal edema, orthopnea and paroxysmal nocturnal dyspnea. There is no history of fever, weight loss, loss of appetite, no history of hemoptysis, no history of headache, vomiting, blurring of vision, no history of back pain, no history of appreciable swelling anywhere in the body, no history of tuberculosis in past or recent cox contact. Past history and family history is unremarkable. Personal history is significant for addictions. Patient has tobacco consumption 1 to 2 packets per day for last 15 years and alcohol consumption 1 to 2 drink per day for almost 15 years. No history of smoking. Patient has mixed diet. Sleep is reduced because of discomfort while sleeping. Treatment history. Initially, patient was treated with oral medicines and inhalers by physician near his home. There was no improvement in symptoms and chest x-ray was done. Patient was explained that fluid has accumulated around his right lung and 2 liters of which was removed. It was hemorrhagic in nature and sent for investigation. Patient felt better after the procedure. When patient reported to our hospital, shortness of breath increased and chest tube was inserted, which was draining 700 ml daily hemorrhagic, and he was started on some form of oral tablet. Chest tube was removed after 15 days. He is symptomatically better after starting treatment. Summarizing, this is 41-year-old male, chronic alcohol and tobacco consumption with no comorbidities, presented with insidious onset, gradually progressive exertional dyspnea, dry cough and pleuritic chest pain for last 3 months, suggestive of right-sided hemorrhagic pleural effusion. My differentials would be malignant pleural effusion and tuberculosis. Going to examination, patient is ECOG performance status.
So we will have some discussion on the history, and so this is basically a 41-year-old male who is an alcoholic and tobacco. He is addicted to habituated to tobacco as well, and but without any comorbidities, right? And he is having, whenever somebody is having breathlessness and difficulty in lying down to one side, what do you think?
So it is there can be 2 differentials for this. Either it is a pleural effusion or it is a consolidation. But his history is more going towards effusion because he does not have any fever, any constitutional symptoms.
So how will you differentiate between the cardiac and the pulmonary origin of this breathlessness?
So the patient does not have history of fluid overload like bipedal edema. He does not have orthopnea. He does not have paroxysmal nocturnal dyspnea, which would have been otherwise. Plus his fever is associated with cough, which is not more of nocturnal. It stays throughout the day. It is relieved with some cough syrup. This all is pointing towards a respiratory pathology rather than a cardiac one.
And again, since no weight loss here, can we consider other reasons for pleural effusion, like connective tissue disorder or any other inflammatory condition other than the tuberculosis and malignant pleural effusion? Consider being a 41-year-old and without any weight loss here.
Sorry, sir, I did not get the question clearly.
What are the other causes of pleural effusion in this age group?
Yeah, so other could be a pneumonic pleural effusion, but he does not have any history of infection. Rarely it could be connective tissue disorder related, but considering male, it would be more of RA related rather than the other one, and it's rare.
Yeah.
So I would just, commonly in exams, but questions are asked when you're when you have such case. So by the history, probably you cannot make out whether this is malignant, benign, and so the only thing that comes out is that this person possibly have a pleural effusion, and probably you cannot dig it down further.
Yes.
The only point, like if you have to keep benign versus malignant, if you are obviously writing a medical oncology exam, the examiners want to listen to the malignant causes, but don't forget the benign ones. At an age of 40 years or 41 years, had this person been like 60 years or 70 years, then possibility of malignancy is certainly higher. But at a 40 years, majority of the time, I mean, it's not the malignancy which you think for as a first differential.
So on examination, this patient has ECOG performance status of 2. Patient is conscious, cooperative and well oriented to time, place and person. Vitals of patients are within normal limit with saturation 99% on room air and respiratory rate of 22 per minute. There is no evidence of paleictoris, cyanosis or clubbing. There is no palpable lymphadenopathy or pedal edema. On inspecting respiratory system, upper airway and oral cavity are unremarkable. Trachea is deviated to the left. Sorry, sir. On inspection, trachea is deviated to the left. Movement of chest are reduced on the right side. There is no intercostal space indrawing or usage of accessory muscles of respiration. Scar mark of pigtail is seen in right axillary area. No dilated veins, sinuses or visible pulsations are appreciated. On palpating, trachea is deviated to the left. Movement are reduced in the right side infrascapular, mid-axillary and inframammary area. Tactile vocal fremitus is reduced in the same corresponding area. On percussion, resonant note is appreciated all over the lung fields except right infrascapular area, mid-axillary line, inframammary area where dull note is appreciated. On auscultation, normal vesicular breath sounds are present on both the sides of lung except for right infrascapular area, mid-axillary line and inframammary area where the breath sounds are decreased. Other systemic examination per abdomen, CVS and CNS examinations are within normal limit. So this is a 41-year-old male with no comorbidity and history of addiction to alcohol and tobacco consumption, presented with shortness of breath, cough for last 3 months. His ECOG performance status is 2. On examination, there was a dull note and decreased breath sounds over right infrascapular, mid-axillary and right inframammary area, suggestive of right-sided pleural effusion.
So what would be your differential diagnosis if we say that this is a malignant pleural effusion in a 41-year-old male?
It could be primary, could be either lung, or it could be hematological disorder like lymphoma can be considered, like DLBCL, or
probably you can put it in a different way, like the 41-year-old with pleural effusion, and most likely if it is malignant effusion, I will think about either primary or a secondary, and the cause of primary is like this, and the secondary is most common secondaries at this age group to the lung are these. You have to present like that.
yes.
So you can now tell me what are the primary. Yeah, others also can join. Yeah, sorry.
So the primary from the can be from the lung, or mesotheliomas, which may present like this, or secondary can be or lymphomas, which may present as malignant pleural effusions, or it may be secondary from other lesions, most commonly in case of females, ovarian carcinomas or GA primary. And
this is I mean, you have to say your differential diagnosis in context of the case.
Yeah.
So this is a 41-year-old male.
Yes.
So obviously ovarian carcinoma is not the differential.
Sorry. Second one, in the background of hemorrhagic, then I would like to say that the possibilities in this case are, it may be reactive pleural effusion also.
The differential diagnosis for a malignant pleural effusion in a 41-year-old male. The question is clear. You have to enumerate the possibilities. As sir said that one can obviously the primary. So primary in the lung, obviously.
Primary in the lung, or
is there any primary in the pleura?
yes, maybe possibilities.
So you mentioned that diagnosis.
Yes, mesotheliomas.
Mesothelioma. So what are the risk factors which you need to see if you are suspecting mesothelioma?
So occupational exposures of asbestos and other things.
And other common secondaries which can go to pleura?
from GI primaries can go to the pleuras.
So how would you evaluate this patient? Like, suppose this patient come to you in your OPD with a report that somebody did a TAP, that's what she told in the history, and said that there are some malignant cells seen. What kind of malignant cells, we are not sure.
Sir, in this case, in the 41 years old, he has a high risk of in the background of tobacco history and with a history of pleural effusion, because our first possibility is malignancy. So I would like to go ahead with directly with CT scan with contrast enhanced with both thorax, abdomen and pelvis. And
are there residents in the audience also? Okay. How many of you would think of germ cell tumor in this patient? No one? Everybody is thinking about secondaries only?
So have you done a examination of genitalia, or you can at least. So, so others, you want to contribute anything? Oh.
Pleural fluid examination.
Yeah, no, we are going to proceed with,
Pleural fluid cytology and cell block you can send.
Okay. So simple examination, a single evaluation like a chest X-ray will be taken, and then you will go for a aspiration, and the aspiration you will be looking for. So you will be asking for a cell block and further examination, right?
So the patient's routine labs were within normal limits that included complete hemogram, kidney and liver function and serum electrolytes. Pleural fluid was exudative, ADA 10 international unit per liter, gene expert negative, cultures negative. Chest X-ray was suggestive of right-sided whiteout lung with tracheal deviation to the opposite side. Pleural fluid cell block done twice. In one cell block there is scanty atypical cells suspective of malignancy. So, patient had an outside PET CT done, and this is a soft tissue window video of the same, which is suggestive of left-sided pleural thickening with effusion and some air pockets within the effusion. Coming to the lung window, there are no appreciable parenchymal nodules or lymph nodes in the same. It's suggestive of effusion with air pockets within it.
So you are what we are dealing is malignant pleural effusion, but without any obvious primary in the. So then how will you proceed?
So sir, twice the pleural fluid cell block has came negative. We can repeat 3 times cytology and cell block and consider sending more of amount of cell block to increase the yield. If still it is not showing anything, then because there is a pleural thickening, we can consider biopsying the pleural nodules and send it for the histopath report.
What would be the investigations like based on these CT imaging? What do you think, what sets of investigations you should do for obtaining a tissue? What are the approaches for obtaining a tissue in these kind of situation where you are not finding an obvious
others can contribute. Yeah. So malignant pleural effusion, but there are no clue to the primary in the lung.
We can also consider doing bronchoscopy if that is giving us a bronchial based nodule, because there is also a lung collapse.
Since
so
this patient has got some moderate pleural effusion and patient is having breathlessness as well, so better investigation would be
getting CT from neck.
Bronchoscopy and more than that, because we want the tissue diagnosis as well, and obviously the pleura is thickened and the pleural effusion, so
video assisted
thoracoscopy, and then it will act as both ways. It will be helpful to the patient, right? Relieving the breathlessness by draining out all the pleural effusion, and we can put a ICD tube as well, and then we can take a biopsy right from the pleural nodule.
If stable, because there is a lot of collapse, so if stable, certainly you should rule out the intrabronchial component if there is an intrabronchial growth, and if it is not there, then the thoracoscopy, and that would certainly have advantage. If it's not a trapped lung, you can do pleurodesis at the same time after doing the biopsy.
So the PET CT did not reveal any distant mets apart from this. The right pleural biopsy was done, which was suggestive of a tumor composed of epithelial to rhabdoid cells arranged in alveolar pattern with marked nuclear atypia, hyperchromatic nuclei, and moderate amount of cytoplasm. On IHC, the tumor cells showed patchy positivity for TTF1, EMA is focally positive, and calretinine is negative. MRI brain was done to complete the staging workup, which does not suggest any evidence of metastasis. NGS of the patient was sent. It was evaluated with Illumina platform, and it was suggested with it was suggestive of TR1 mutation in EGFR, PL858R mutation with EGFR amplification and TP53 mutation.
So, what would be the minimum set of molecular testing which you would suggest in such a scenario? He's a young patient, he's a non-smoker, although tobacco chewer, but patient has been a non-smoker. When you did an NGS, that's fine, but if you find this as a new case, what would be the minimum set of molecular markers you would like to have?
EGFR, ELK, EGFR by RT-PCR, ELK and ROS by IHC, and PDL1 testing will be the bare minimum I'll be doing to begin with if I'm in resource constrained settings or the NGS is not available easily. And
what
then
is optimal? But
sorry sir, what
is optimum?
20% of the tissue.
Yes.
When you say NGS, I mean what NGS? You want to do like 100 gene, 200 gene, 10 gene, 5 gene, what exactly?
You want to do a comprehensive gene panel or a limited panel?
at least a limited gene panel of 14 genes should be
So
considered.
he is asking what are the commonly tested and clinically useful mutations.
So, that number of genes which need to be tested when we say that optimum testing.
They are mandatory right now. They are mandatory. And what are these mutations?
So a limited gene panel consists of 14 genes where we are looking at the common EGFR ALK cross mutations. Apart from that, we are looking at ERBB2 fusions, NTRK, RET, MET amplifications and mutations. Fusions.
So, how do you interpret this report?
So this patient has a canonical EGFR mutation, classic sensitizing L858R mutation. Along with that, he also has a coexisting TP53 mutation with a VAF of 76%. There are many studies which are suggesting that the TP53 mutant along with EGFR concomitant could bear the resistance to TKIs, and might be chemo with TKI would be a better idea to go along in such patients. Yeah.
What would be the implication of EGFR amplification? Because these are the three anomalies which your report has mentioned. So we just want your thoughts on each one of them.
So the EGFR amplification at this point of time, so if it is an isolated EGFR amplification without any classic sensitizing mutation, it does not render the tumor sensitive to TKIs. In certain cases, when the patient progresses on EGFR TKI, EGFR amplification is one of the resistant mechanism to the EGFR TKIs.
What's the relevance of variant allele frequency, and what do you mean by variant allele frequency?
Variant allele frequency is the time a particular variant or a allele is read upon the number of total reads the NGS has taken. So it implicates the intensity of the particular mutation that will be present in the tumor cells. So a higher wave implicates that this mutation might be present in more, it is quite significant.
Any particular value that beyond that it's more significant, or it's less than that, it's not going to work? Any other?
So I'm not very sure about lung, but in CLL there are cutoffs and there are studies related to cutoffs of TP53 where we are considering the venetoclax and therapies.
Go ahead. Before management, I would like you to mention the stage of the disease. Just summarize the complete diagnosis, which should include the age of the patient, comorbidities, performance status, stage, histology, and molecular markers. One slide. And I mean, when you are presenting a case, before moving on to management, please give a complete diagnosis, including the factors which affect your management plan.
And also the PDL1 status. Have you seen the PDL1 status? No. Yeah, she asked me.
So it was negative.
Okay.
So this is a case of 41-year-old male, no comorbidities, never smoker. Case of metastatic CA adenocarcinoma lung, clinically TXN1, M1A, with the site of disease being pleural effusion.
N1 doesn't have A or B. It's M1A.
Sorry, M1.
Okay. So this is M1A disease, right?
M1, sir.
Anybody
M1A,
else? As per AJCC 8, how many subclasses are there for metastatic description?
A, B, and C.
B, C. 1A is effusion pleural or pericardial. B is
Only
only number of
effusion?
one distant metastatic site.
M1A.
It is intrathoracic mets, so a contralateral lung met, pleural effusion or pericardial effusion confides 1A. 1B is a single extrathoracic met, mets confined to a single extrathoracic organ, and M1C is multiple extrathoracic organs.
So each one can tell us their approach in this particular situation where you are having a patient, 41-year-old, with stage 4 disease, stage 4 M1A disease.
And performance
And
status 2.
Correct.
That's what.
Yeah.
So we'll go ahead with immunotherapy with, TK osimertinib with chemotherapy. Because the patient is having EGFR amplifications also in this. First line will be based on the FLORA-2 trial. I would like to go ahead with osimertinib with chemotherapy, PEM with carboplatin.
As there is no any brain mets, it's not any poor prognostic factor, so only osimertinib alone only in this young patient.
So you so you want to reserve osimertinib for only with those who are having brain metastasis?
You want to give chemotherapy with osimertinib only to patients with brain metastasis?
Yeah, that combination is, you will offer combination only if they have brain metastasis? So it's very clear, the young patient who has stage 4 disease and EGFR positive disease, patient is anyway you are aiming at a long, either he should get a long OS or a PFS, right?
So the factors which you would consider here, what she mentioned, that one, that this disease looks like a high-risk disease because this patient has a P53 co-mutation, right? Which at least there are some these combination trials which have considered these factors at high risk. Chemo TKI combination is now more or less established. Certainly it is at the cost of higher toxicity. But this patient, what you mentioned, that had performance status of 2 is possibly because of a lot of pleural effusion, right? And he's a young patient. I'm sure would not be having too many comorbidities. So if a young patient with a larger disease burden, patient is symptomatic because of lot of pleural effusion and entire lung is collapsed, you need the most effective therapy available, right?
Yes.
So any other thoughts on the selection of TKI or any treatment? Any other combinations
Apart from these
apart
two
from
options,
this?
what options you will?
Currently, the data for amivantamab plus lazertinib in first line is coming up, but the OS data are not mature yet. So that is the option.
Any other option, like, because he has got only pleural effusion and basically it's pleura alone involved lung cancer.
Sir, allotinib and
Decomaten.
allotinib with bevacizumab.
Yeah, exactly. Or ramucirumab plus erlotinib also is a good combination.
So if you choose to give osimertinib with chemotherapy, so how would you give? I mean, the number of cycles, and when would you do the response assessment?
So first we'll start with, since his initially he has already been started on some form of chemotherapy tablets, that is what is mentioned in history. So whether Jeff or osimertinib will continue it and will add chemo considering his burden of disease. So we'll begin with pemetrexed carboplatin. We'll give it every 21 days for 4 cycles, followed by response assessment. So that will be around 3 months from the start of therapy. We'll go ahead with the first response if he does not worsen in between.
4 cycles of platinum doublet along with TKI, followed by maintenance with
Pemetrexed plus
and
TKI.
TKI to be continued. Fair enough. What would be your expected response rates and expected progression-free survival and overall survival in these kind of scenarios if you use this combination?
Response rates are somewhere around 80%, with median progression-free survival of 23 months as per FLORA-2 trial. And 1 year OS reported is 76%, I guess.
After 4 cycles, the evaluation showed complete disappearance of pleural effusion, but the pleura is thickened and the lung is collapsed. Then what will you do?
So we'll still continue with the further treatment on the same lines.
So you are continuing osimertinib for another 3 more months, and repeat CT is showing the same picture. Then what will you do?
Yeah, so the response is maintained. I'll still continue same.
All right. So you gave this combination, patient did well. After 2 years, patient progressed. I mean, with the subsequent scans, you found that there is a new liver metastasis. How would you deal with this?
So first need to see that how much suspicious that liver lesion is, because we would have done CT. We'll get a correlation if it is really suspicious. Now the question is single mets.
It's a confirmed metastatic lesion. Okay, it's a single liver lesion. How would you deal with it?
You should rebiopsy the liver
Rebiopsy the lesion.
So we should find out whether it is any resistance to that osimertinib, or there are new pathways.
So what are the common resistance? So we have 1 more minute.
Yeah.
So what are the common resistant mutation in patient treated with osimertinib?
Some
C797S.
MET amplification.
MET amplification. That's it.
HER2
amplification.
It could be EGFR.
You want to see the resistance mechanism and pathway, and you are mentioning only one mechanism?
It could be EGFR dependent or EGFR independent. EGFR dependent could be, if we have used osimertinib in first line, it will be C797S. Right. If we are using first, second generation in the first line, it would be T790M commonly.
We are using osimertinib, so I'm asking for in particular osimertinib.
C797S or EGFR amplification. EGFR independent mechanisms would entail MET amplification or ERBB2 amplification, or it could be a small cell transformation.
Okay. So this patient did not have a transformation. The liver metastatic biopsy shows adenocarcinoma. You did an NGS. It did not show any other mutation apart from the founder ones, but there was a MET amplification. How would you take it forward from here? That's the last one.
There was
So
a
Mariposa trial will go with amivantamab lazertinib with this patient.
How would you treat this patient? Mariposa trial had done whatever.
If you have
Please
only
don't
single liver
answer
lesion,
these
then
things
we
in
can-
exams. When exam, if the question is, what would you do?
It is
Only
a
lesion
single
in the-
liver lesion. We'll see whether it is amenable for a local therapy or not, considering SBRT or RF ablation. And we'll continue to just improve our PFS, and then we'll reserve the second other drugs.
Please remember the role of local therapy even in the progression. Okay, and continue osimertinib after tackling the local. Thank you so much, and yeah.
Like this, in a setting like this, so since we have the TMH study available of Jeftinib plus chemo, so let's say the patient is not affordable osimertinib, or we want to save osimertinib for the second line since it is the next generation and we don't know like what all options we have, because everyone is not going to have amivantamab and lazertinib. So would this be an eligible option to start patient on Jeftinib plus chemo as first line and then keep osimertinib as in the bank for the second line?
So if you say that I want, there is one thing, that patient is affordable, non-affordable. Well, I mean, large majority of
Definitely, there is
patient
no
in our
option
country
that
may
you
not be
will
affordable for this. So for them, the combination of first generation TKI with chemotherapy is a very valid option. And probably that's what majority of our people get. But if you say I want to reserve osimertinib for second line, that's where probably I would say, I mean, if somebody is affordable for osimertinib in second line, can be affordable in first line also.
No, you don't want to reserve it intentionally. You
So,
would always
because
give
if you use osimertinib as second line, you need to understand that you can only use it for patients who develop a T790 mutation, which probably half of your patient would develop. And half of, out of those 50%, probably you may not be able to pick it up by your conventional testing methods in another 10-15%. So proportion of patients who had EGFR positivity, sensitizing EGFR mutation, if you reserve osimertinib for second line, you may not be able to use it for almost 60% of your patients.